Now move to the next theme, which is community education and data complexity challenges. Would request Syed Ali to.
I work in the Lines Aravind Institute for Community Ophthalmology.
You're not audible.
Oh, sorry. Is it audible now?
Yes.
Yeah. So I'm Syed. I'm representing Aravind Eye Care System. And my work is basically mentoring other eye hospitals. So we engage with other eye hospitals and we kind of train them to put up systems and improve their performances kind of thing. That is one of the core work. And secondly, I'm also part of the central operations at Aravind Eye Care System. So just a little bit of context as to what I'm presenting, which will be a very simple analysis of retrospective data from Aravind Hospital in Madurai. So we are trying to, like, when we work with the hospitals, so we frequently encounter questions like the uptake is very low, our acceptance rate is very low, there are a lot of barriers, patients are coming from long distances. If closer, patients will be easily able to take up surgery, and then like gender and other age and other things comes up. So the primary question was like what it is like, because Aravind is the proximity of Aravind is there, and the data is also there. So can we kind of understand like how this compares with Aravind? So what is our own thing when it comes to distance and other demographic aspects of uptake for cataract surgery? So that's a background for this. And we try to analyze, like there are some studies which talk about distance, but not very detailed, and it's very hard to say whether distance really matters or not. There are some studies which say distance doesn't matter. And also like we are actually comparing like age, gender, occupation, and systemic illness, and even visual acuity, and how it kind of influences uptake for cataract surgery. We were trying to understand in this analysis. And as I was mentioning, this is a retrospective cross-sectional study, and this deals with the direct walk-in patients of the paying side. And the data is taken from Jan to December 2024, and we have included all the patients who had come to the hospital, underwent a comprehensive eye checkup, diagnosed with cataract, and got an advice for cataract surgery also. And one of the inclusion criteria is the patient should have accepted, underwent the cataract surgery within 90 days from the date of advice. So that including in this study, and above the age of 40. So we have removed all the cases which are less than age of 40, and we are focusing only on patients who are coming from within the state of Tamil Nadu. So we understand that Madurai is kind of at the center to the state of Tamil Nadu. So we thought the surrounding can be taken for consideration. And what we have excluded is patient referred from other hospitals. They would have already advised for cataract, and maybe they would have come already motivated for cataract. So even patients from vision centers, for patients from other Aravind centers, we have excluded from this study to just to take out that bias. And then we have also removed all the combined procedures along with cataract. So we are keeping only cataract surgeries, both LAICO and SICS included. And these are the various things studied, like age, gender, and systemic illness and other thing. And for distance, we are only taking the straight line distances as the crow flies. And so we are using a Haversine formula to calculate the distance between two lat longs or something like that. So that's what we have done. And these are the results. So for this study, it was like 51,262 patients were included in this thing. This is for 1 year data. And of this, 40,703 patients have underwent surgery. So which is the overall acceptance rate is 79%. And 93% of this operated patients underwent surgery within 30 days from the date of advice. So in terms of age, this is what we understand, that as the patient age increases, the likelihood of undertaking surgery also increases. And this is a very significant trend that we have seen. And even in a multivariate analysis, this seems to be a stronger thing. So as patient's age increases, the likelihood of surgery also increases. And second is gender. So women are slightly more likely to accept surgeries than male. And so if you see the overall acceptance rate, so it's almost like similar, 79% for male and 80% for female. But there is a statistically significant thing in the univariate analysis that women have slightly higher chance of taking up surgery based on advice. But in the multivariate, this significance doesn't arise. And in terms of occupation, so we have categorized all the patients into 4 categories: unemployed, unskilled, semi-skilled, and skilled. And the analysis is showing us that among the unemployed sector, the uptake is very, very high. And the unskilled and semi-skilled and skilled, the uptake is slightly lower. And this is what we have seen. And in terms of systemic illnesses, of the total patients who in this cohort, around 50,000 odd patients, 66% of patients had some form of systemic illness, and 34 patients do not have any of those 5 listed systemic illnesses here. And what we understand is the patient with systemic illnesses have slightly higher odds of undergoing cataract surgery. So patient having any chronic conditions are likely to adhere to the surgery advice that the hospital is giving. And in terms of distance, so this map quickly explains like the center dot, which there is a plus, that is Aravind Hospital in Madurai. And all those green dots are patient advice for surgery and taken up surgery. And all the red dots are patient advice for surgery and not coming for surgery. And we have categorized the distance into 4 different categories: less than 50, 50 to 100, 100 to 150, and 150 and above. And we are comparing 150 as a reference that we are keeping. And interestingly, what we had seen is patients immediately around the hospital, the uptake is very low, 4%, they are less likely to undertake surgery. This is very surprising. At the same time, the inference is there might be a lot of service providers, there may be a lot of options for patients to choose from or something like that. And patients who are in the second category, 51 to 100. So even though this is one interesting insight, like the market is still outside at large. Like people outside your immediate service area may still see you as your potential and the best partner to undergo cataract surgery or something like that. And those actually connects a lot of rural areas also. So that makes a lot of patients in the 51 to 100 is likely to undergo cataract surgeries more than who are nearer you. Yeah. Just so in the visual acuity category, like 6.6 to 6.8. Sorry, I don't know. Yeah, I'll just quickly through. So what we have done a small. Curious what is happening on the free section also, because what we have seen far as the subsidized section. In the free section also, we had seen similar thing, like women are more likely to get operated, and also like the semi-skilled and skilled patients are lower getting operated also, and patients of all age group better acceptance on the free section and subsidized section also. Yeah. And the implication, like one of the things is like everyone underwent a comprehensive examination. So what we see is like these barriers doesn't actually really matter. Like if you have a comprehensive setup and the advice and the education of the patient is going correct, I think patients are more likely to cross this barrier and come for surgery. And also like surgery and counseling and institutional trust also plays an important role. And another thing is like there can be like external factors also may be affecting the development of the area, the health-seeking behavior, and other environmental influences also will be, that is not studied in this thing. So even though we have used a prospective data, there is a lot of inferences it is giving to do some prospective analysis later. So we are currently using only retrospective, so a lot of prospective analysis can be done later also. And the novel methodology, we have used the geocoding. So we use lat long to understand the exact distances that where patients are coming. So one challenge that we had is we are using 50,000 data points. So there are a lot of missing data, the address data, a lot of patients doesn't have the pin code and everything. So we have to adjust, either if the pin code is not available, we use the village name or the area name kind of thing. So that proved a little bit challenging. But we believe that in order to understand the uptake, we can still use this as an efficient methodology and automate it to make it more relevant to our context. So, thank you.
Later.